I thank for this opportunity to Vijay Kumar Badasa and the organizers. I have a disclaimer to make. My presentation is going to be a repetitive one because the diagnostic part already beautifully dealt by an expert endoscopist. But as this is a diagnostic pulse in a early esophageal cancer, and endoscopy is the main thing. With my limited knowledge of endoscopy, I am trying to explain, and expert endoscopist is available. I would like to be corrected. This is already discussed. What is early esophageal cancer? T in situ, T1A and T1B, that is limited to mucosa and submucosa. The most important thing here is SM1, that is up to 1/3 of the submucosa. It has some clinical importance. So diagnosing early esophageal cancer, does it really matter? Should we discuss that? Because already the discussion is going on, the Indian scenario, it's all advanced. Maybe future, maybe after 20, 30 years or 25, 30 years in India also, we may be discussing in detail this early esophageal cancer. Why it is important? T1A, see the lymph node metastasis, it is less than 2 to 4%. And T1B, especially SM1, which is 1/3 of submucosa, it is only 10 to 20%. So this is very important because the early cancers have very less lymph node metastasis. And there are many trials which also said, one of the trial also says that SM1 depth invasion also has a limited lymph node metastasis. So even the 5-year survival rates, if we compare, T1A is nearly 90% and T1B S1 it is 80% and T1B S2, SM2, SM3 it is nearly 70%. So we have something to offer to the patient. If the esophageal cancer is diagnosed early, there is a curative potential by endoscopy, especially T1A lesions, and there is also the survival benefit. Now coming to the diagnostic pulse, what all the pulse I have to diagnose the early esophageal cancer? The most important pulse I have is the history taking, which is, there is no second thing other than the history taking and identify the high-risk patients. The other diagnostic pulse are advanced endoscopy, endoscopic ultrasound, histopathology, and PET-CT. Should we screen esophageal cancer patients because we screen colon cancer in GI cancers? There is no association as advocated screening protocol, at least for now, to esophageal cancers, but ACG in 2002 has said there are some patients in which there are chronic GERD patients for 3 to 5 years with some risk factors. There are 3 to 4 extra risk factors other than GERD, like male gender, 50 years age, family history of esophageal cancer, central obesity, smoking history. These patients can be screened for CA esophagus. And there are other high-risk factor for squamous cell carcinoma, like alcohol intake, tobacco intake, achalasia cardia, caustic injury in the past history. These are prone for squamous cell carcinoma. These patients can also be screened. The second armamentarium or the second important tool which I have is endoscopy to screen, to diagnose these early cancers. We have this endoscopy sitting in a big gun machine and firing all the bullets of what all the endoscopy can cover. High definition, white light endoscopy, this high definition will enhance the local area and it will be able to pick the abnormal areas. Next is coming to chromoendoscopy. As Dr. Srikanth has said, there are dyes, indigo, carmine dye, and acetic acid. Acetic acid, they spray that dye, and when there is intestinal metaplasia, there will be transient whitening of the intestinal metaplasia, and that the dysplastic epithelium can be picked up. Similarly, Lugol iodine, which again Dr. said it is. Then we have virtual chromoendoscopy. This is again only limited wavelength blue and green lights are used. NBA, iSCAN, FICE, they are all the same. They are brothers from different companies. Then we have laser microendoscopy. It is similar to seeing the histopathology through endoscopy. Laser 488 nanometers light and focally it is placed, and histopathologists may be needed to diagnose during endoscopy. This is again wide area transepithelial sampling. This is like brushing all the esophageal epithelium. This is especially helpful in Barrett's esophagus where some areas can be missed. So this is Lugol's iodine, where the bare patch was diagnosed. This squamous cell carcinoma. This is again NBI image, which was previously discussed. So when the endoscopist sees the area, what should be done? So they should be looking for mucosal irregularity, nodularity, and mainly color change. When if there is a raised or nodular lesion, EMR should be done, not a biopsy. Biopsy is only when there is less than 3 mm lesion. There is a Seattle protocol is also discussed. This is a Seattle city which you are seeing, and postgraduates can remember this. These 4 quadrant biopsies are taken at 1 to 2 centimeters length. Suppose, and every biopsy you take has to be marked at the length of the esophagus taken and the quadrant mentioned. This is a cumbersome procedure, and then can be errors. What about after biopsying? How do you surveillance these patients? If there is no dysplasia, there is 3 to 5 years is low-grade dysplasia every 6 months, high-grade dysplasia 3, 6, or 12 months. But make sure that if it's low-grade dysplasia, you are doing RFA, and if high-grade dysplasia, you are doing EMR. Now the endoscopic ultrasound. Endoscopic ultrasound is very useful in early cancers. It is able to distinguish between T1A and T1B. Why it is important? T1A, endoscopically, we can cure the cancer. T1B, only in selected cases, SM1 lesions, where lymph node metastasis is limited and there is no lymphovascular invasion. After MDT discussion, we can go for endoscopy therapy. And also for lymph node staging, if there is lymph node, it is very good in sampling the lymph nodes and also diagnosis malignant lymph nodes, so that we can decide where the patient is going for endoscopic resection or esophagectomy or neoadjuvant therapy. But not all endoscopists will directly do the endoscopic ultrasound. There are some parameters where expert endoscopists will decide based on the features. If it is less than 2 centimeters, it is not depressed lesion, and on chromoendoscopy, it is vascular pattern. PET scan, not much useful in early cancer. Lymph nodes are understaged. Many studies proven that the pathological specimen has more lymph nodes. So artificial intelligence or molecular waves are coming with the key takeaways are screen high-risk population, use white light endoscopy, NBI, Seattle protocol for Barrett's esophagus, biopsy the suspicious areas, use 4 quadrant sampling, dysplasia is deal the dysplasia, do EMR or RFA, endoscopic ultrasound is used to differentiate T1A and T1B, and do EMR. EMR and ESD is both diagnostic and therapeutic in T1A. PET has limited role. Thank you.